Hello everyone, I am Dr. Santosh Kumar, Orthopaedic and Joint Replacement Surgeon based in Kolkata and the founding director of Momentum Orthocare. Well, the concept of Momentum Orthocare is that we share the knowledge, we share the expertise, and we have built a team which is highly dedicated, highly professional team to bring the very best of joint replacement surgery to Kolkata, and we facilitate the people of India and the adjoining countries, to facilitate the people of Eastern India to get the very best in joint replacement, hip and knee replacement at the most affordable prices right here in Kolkata. So if you have any issues, you are most welcome to come to Kolkata and we'll assist you in all possible ways. So we had been discussing the pathologies of the hip joint and hip replacement. So just before this, we had discussed about avascular necrosis. The second commonest cause that we find in Eastern India is ankylosing spondylitis. Well, just to remind you once again, this is the hip joint. This is the hip joint is the joint which joins the thigh with the pelvis. So this is the hip joint. This is a ball and cup joint, and this is the biggest joint in the body. The hip joint is the single biggest joint in the body. It's the ball and cup joint, and hip joint arthritis leads to severe pain in the groin and front of thigh, and it's not only walking that is painful, it's sitting, lying down and sleeping also is very painful. So it is one of the most incapacitating things which limits our movement, and hip replacement is the most life-changing surgery in medical science. It drastically improves the life and the quality of life and mobility. So we just discussed about avascular necrosis. Ankylosing spondylitis is another cause which of hip arthritis. Ankylosing spondylitis is a systemic disease, unlike avascular necrosis of hip. What it means is that it affects multiple places. Ankylosing spondylitis is basically a disease of the spine which also affects the hip gradually. So to start with, there is low back pain and stiffness, and there is sacroiliitis which leads to pain in the buttocks, and there is difficulty in forward bending. There is difficulty in deep breathing because it affects the chest, and there is fatigue, loss of appetite, there is loss of weight, and once it starts affecting the hip joint, there is groin pain, difficulty in walking, antalgic gait means painful limp and difficulty in sitting, lying down. All those hip arthritis problems start. So, and ankylosing spondylitis also affects the eyes, which is known as uveitis. So eye checkup for ankylosing spondylitis patient is also very necessary. Now, the treatment of ankylosing spondylitis starts with exercises, because most important thing is early detection. Whenever we suspect ankylosing spondylitis, we have to diagnose ankylosing spondylitis first. It is quite related with a gene called HLA-B27. We do a blood test to find out the gene, to locate the gene HLA-B27 in the person. We do other blood tests like C-reactive protein and all to find out the amount of inflammation. We do an X-ray of pelvis to see sacroiliitis, that is the inflammation in the sacroiliac joint. So that is very characteristic of ankylosing spondylitis. And then we do eye checkup to rule out uveitis, that is affection of the eye. Now we must understand that back pain is not ankylosing spondylitis. So back pain is not equal to ankylosing spondylitis. Spondylitis is colloquially used as any pathology of back is called spondylitis. So that's a completely different thing. Ankylosing spondylitis is a completely different thing. Ankylosing spondylitis is a very specific disease entity. It is not spondylitis. Ankylosing spondylitis is a very specific disease entity which needs to be diagnosed. So it is a progressive inflammation of the spine. It is a progressive inflammation of the joints of the spine. So this is a progressive inflammation of joints of the spine, and it affects the hip also gradually. So once it is diagnosed, physical therapy is very important. Ankylosing spondylitis normally starts from 20 to 25 years of age. It runs the usual course of the disease is inflammation and pain goes on till 20-25 years, and then after that the pain gradually subsides, inflammation subsides, and there is a residual stiffness which persists. So the problem of ankylosing spondylitis is pain to start with, and then it gradually fuses the joint. So once we have diagnosed, we start physical therapies and exercises. Various types of stretching exercises like yoga, swimming, other stretching exercises are done. Painkillers, biological treatments. Once ankylosing spondylitis is diagnosed early, we can give biologics to prevent the progression of the disease. We cannot eliminate the disease, we cannot take out the disease because it's there, it's a genetic disease, but then we can prevent the progression of disease by using several biologics. sometimes steroids are used, disease modifying agents are used, and once it has affected the hip joint and it is causing significant problem in hip joints in terms of painful limp, walking, difficulty in walking, difficulty in sitting, then we have to do hip replacement. In X-ray, like to diagnose ankylosing spondylitis, the earliest thing that we can do when we suspect ankylosing spondylitis is to do blood test to locate HLA-B27 gene to see inflammation in terms of CRP. Once ankylosing spondylitis progresses in spine, we can see fusion of the spine. So we can see fusion of spine, and this is known as bamboo spine. So it looks like a bamboo, and this is the fusion of the spine. Basically the ligaments are fused, and sometimes it causes discitis also. So disc and ligaments are fused, and once it starts affecting the hip joint, there is arthritis in hip, which we can see in X-ray. Presence of hip arthritis, which we can see in X-ray. In X-ray also we can see very early arthritis. We can see very early arthritis. Once it affects the spine, gradually it can go and affect the hip, which causes hip arthritis. Now we have to understand that ankylosing spondylitis is a complete spectrum of disease. Sometimes it affects spine only, sometimes it affects hip only, sometimes it affects both. So the problem with spine is that it goes towards fusion. So there is the movement in spine stops. If somebody's lumbar spine is affected, they will find difficulty in bending down. If somebody's cervical spine is affected, then head will not bend down. Several cases only spine is affected, several cases only hip is affected, and in several cases both hip and spine are affected. So it causes hip arthritis. As we can see, it causes hip arthritis, and it affects, majority of the cases it affects both the hip joints, right and left, both the hip joints. And X-ray is a basic test to see this arthritis. X-ray is a basic test to see this hip arthritis, and the solution of this hip arthritis is hip replacement. So hip replacement, we basically replace this ball and cup. Like this side is relatively normal, so this is the ball and this is the cup, which has been damaged, which has been destroyed in this side, left side. So we replace this ball and cup with a prosthetic ball and cup, and that is known as hip replacement. So this is a hip replacement. The cup is placed, the femoral head ball is placed, and there is a stem which goes inside the femur bone. There is a stem which goes inside the femur bone. So this is the basic structure of a hip replacement implant. Now this fixation and fixation with of the implant with the bone can be by two means. One is using bone cement, that is known as cemented implant, and the other one is without using bone cement, wherein the implant is designed such that it goes and fits there. There is press fit, there is scratch fit, and it is coated by porous coating so that bone ingrows in that. So that is known as non-cemented. So both ways of fixation are there, and it's the choice of surgeon to choose which one is ideal for the patient. Normally, if the bone stock is good and younger patient, we do uncemented, and in older patients we may do cemented implant when the bone is not very strong. Several times we use hybrid. What it means is the cup is uncemented but the stem is cemented. So that is known as hybrid hip replacement. So that is also used several times. Now the structure of and the most commonly used hip implants are non-cemented hip implants nowadays, and this is the basic structure of a non-cemented hip replacement implant. This is the cup. This is the cup. It is made up of a material called titanium mixed with tantalum, and it is highly porous coated. It goes and scratch fits in that. So it is of multiple sizes. The persons, every person may have different size. Like every person may have different shirt size. So similarly, the sizes are multiple sizes are there of adequate size. This is this is non-cemented, and there are multiple some holes are there to put screws if necessary. And once the cup is fit, there is a liner, and this is the head. So there is a bearing surface. So basically, there is a bearing surface, means the surface of the head, and then there is a liner inside the cup, and this is the bearing surface. In this diagram, we have shown ceramic on ceramic bearing surface. But most commonly used bearing surfaces are ceramic on poly or metal on poly. Like as far as the cup is concerned, we prefer to use ultra high molecular weight polyethylene nowadays, highly cross-linked ultra high molecular weight polyethylene. And this head can be either ceramic or cobalt chromium. And the stem shown over here is another, again uncemented. It is porous coated and it is scratch fit. It is press fit. So bone ingrows in that. So the The concept of this non-cemented implant is that it is press fit and bone ingrows in that after some time. So the stem can be, stem is of various designs, like this is a fully non-cemented, this is a fully cemented. Cemented stems are normally smooth and non-cemented stems are porous coated. And non-cemented stems can be of two types, fully coated and this one is proximal coated. What it means is that it can be only the upper half can be coated. So there are various logics in that. This is the most advanced system, proximally coated system. So this is one of the most advanced system. Several times we put cemented implants generally cemented implants are put in older people where the bone is not very strong, and non-cemented implants are put in younger people where the bone is strong. But whenever we do non-cemented or cemented, we always keep both the systems ready in our surgery, and we decide based on the actual findings that we get on the table whether the bone is strong enough or not. Sometimes when we plan non-cemented, we may shift to cemented. Sometimes when we plan cemented, we may shift to non-cemented. And hybrid systems are very commonly used nowadays, wherein the cup is non-cemented and the stem is cemented. Whenever it comes to revision, like suppose if the very young person is going for a surgery, we may put cemented or uncemented both, non-cemented both, because one logic is that non-cemented stems are may survive more than the cemented stem. That is one of the logics. But another logic is that if at all we have to revise it after maybe several decades, 30 years, 40 years, 25 years or 30 years, then in that case revision of cemented is easier than non-cemented. Non-cemented revisions are difficult, although non-cemented lasts very longer. So it is completely based on the expertise and the experience of the surgeon, which implant to put, which implant to use. But by and large, there is tendency of non-cemented implants nowadays. Sometimes the femoral canal is very narrow and we may not be able to put the minimal size of the non-cemented implant. In that case, we have to put cemented implant. So it's nothing is hard and fast. It depends on the table, and plans can change on the table also. So these are the various types of stems that were used: non-cemented, cemented, fully coated, proximal coated. So as we discussed, these are the various types. And this is the X-ray after hip replacement, wherein the implant can be seen. This is the femoral stem, which is fixed in the femur bone. This is the head, this is the cup, and this is the ball in cup mechanism. And this is the conventional non-cemented, where the head is 28 millimeter. And nowadays we have a tendency to use larger head, like 32 millimeter, 36 millimeter. But that again depends on patient to patient. Like if the acetabulum size, this is known as acetabulum, the cup. If the cup is very small, then we cannot put very big head. So, but we prefer to put larger head. This is larger head. This is standard head. Larger head gives more stability, gives more range of movement, as we will see subsequently. We prefer to put larger head, but again it depends on patient to patient based on the size of the cup. We cannot forcibly put larger head if the cup is small. So everything has got its own fixed criteria, and that only a surgeon can decide on table which is the best thing to do. So just going through once again the components of the hip replacement. These are the stems. Sometimes we use long stem whenever the proximal fixation is not good, there is a fracture, or whenever we are doing for the second time. Sometimes we are doing for the second time, then we have to use a long stem. And there are various revision systems also available, like once a hip replacement has happened and then it has to be redone again, in that case revision components are used. But this is the basic component. This is a non-cemented stem, this is the head, this is the liner, and this is the acetabular shell, as we have seen. Now just coming to the cup once more, this is the acetabular cup of a non-cemented total hip replacement. This cup is made of titanium and tantalum, and it is highly porous coated from outside, and multiple screw holes are there just to fix it. This is a liner. This liner can be a metal liner in dual mobility cup, or it can be a polyliner. So this is the composition of a dual mobility cup. The word dual mobility means there are two heads, so it gives even larger range of movement. So this is dual mobility. So there is a cup below this, inside the cup, there is a metal liner, and this head, which is made up of ceramic or metal, and on that head there is another umbrella. So that makes it dual mobility. There are two components of the head. So this is a dual mobility assembly, dual mobility cup. There is a cup, there is a liner, and the head has got two parts. There is outer umbrella and inner core. So that gives a better range of movement, more stability, and it allows a person to sit cross-legged and all those things. But it's not that dual mobility cup are always superior than standard large head cups. It's not like that, and everything depends on the surgeon, pros and cons. Dual mobility is supposed to give more stability, hence it is more important in cases where there are chances of instability like muscle weakness, neurological diseases. In young patient, dual mobility may or may not be the best option, and the large heads may or may not be the best options. So it depends on the surgeon. How dual mobility gives a better range of movement, like the cup, the surface area is increased, so it gives a better range of movement. Like a person can sit cross-legged, person can do gymnastics, person can squat. So that is the advantage of dual mobility cup, and this is the basic construct of a non-cemented stem with non-cemented cup and a dual mobility cup. We very frequently use dual mobility cup nowadays, and presently we are using robotic arm assisted hip replacement, which uses MIS technique. Now what is this MIS technique? It is minimally invasive surgery, and the cutting is small, the muscles are preserved. It's not about the skin cutting, it is about the muscles are preserved, the abductors are preserved, the core muscles are preserved, so the patient can walk normally, and the patient starts walking from the very next day of surgery. So we have been using robotic arm assisted hip replacement, which basically uses navigation for better component placement and sizing. Now we must understand that whatever type of hip replacement implants that you use, the single most important thing is the precision. It's all biomechanics. It's all biomechanics. Is the precision which is the single most important thing, and this precision can be enhanced by using robotic arm assisted surgery. And to enable accelerated recovery, we are using MIS technique, minimally invasive surgery. So this is a photo of one of our patients, international patients, whom we had done both sides hip replacement, and the patient had been jogging, running after hip replacement after a month. This is one of our patients in which whom we had done hip replacement. He is from a neighboring country, and he has been squatting right here. And this place where he is sitting cross-legged after hip replacement is in Salt Lake, Kolkata, and he has been very successfully doing all his work. We had another patient. This patient hip replacement was done, and then he started walking from the very next day, and we have been doing many such patients in which both sides hip replacement was done, and the patient started walking from the very next day of surgery. So hip replacement in hip arthritis, it is a life-changing surgery, and it is something which changes life overnight. Means a person who had been suffering from hip pain for several years now starts walking normally, and starts being like a normal person. It's a life-changing surgery, and it restores painless and stable movement, and that's the goal of our Momentum Orthocare, to restore the joy of movement, to restore painless and stable movement. And we are committed to bring the best in knee and hip replacement to Kolkata, and all of you, whomever you know, family members or friends who need hip or knee replacement, are welcome to Kolkata. We will assist you in all possible ways, and we ensure you that we will give you the world's best at the most affordable prices. We at Momentum Orthocare are committed to restore the joy of movement, to bring the very best of hip and knee replacement to you, and we are available at Kolkata. So we are a big team with me, other orthopedic surgeons, and paramedical professionals, assistants, technical OT assistants, physiotherapists. So we are a big team of around 100 people, and we operate in 2-3 hospitals. And the most important thing is that we help everybody and anybody who needs that treatment. So we make sure to make the whole thing as smooth as possible. If you have any of those insurances, we make sure to make it cashless. We serve in our hospitals. We serve for all nationalized insurances like National Oriental, New India, United India. Most of these nationalized insurances, they have fixed package without any breakup. So that's a good thing. And some of the private insurances, they also have a fixed package like Star Health, HDFC Argo, Bajaj Allianz. So they have fixed package. And then there are some other insurances which we have been serving like IFCO Tokyo, ICICI Lombard, Royal Sundaram, Max Bupa, Niva Bupa, all those insurances which we have been serving. And we make sure to that a patient having these insurances gets the treatment in a cashless way. We make the whole treatment cashless. And if a person is having any of those state or national insurances like state sponsored insurances, that also we make sure that the person gets the best possible treatment in that. And most importantly, if anybody is not having any insurance, we make sure that we give this world class treatment to that patient within the budget of that patient. So sometimes the choice of hospital may vary based on the budget, but we make sure that the treatment is same, whether the hospital is very big or relatively moderate hospital, but the treatment is same, and we make sure for that. So we are committed to bring the best of knee and hip replacement in the city of Kolkata, smoothest way and within your budget and affordability. Thank you.